10 seconds because it's now 3:45. Hello, everyone. Welcome to this session of the 2023 Culture of Data Conference. I hope all of you are having a great day today, and I want to thank you for joining us. My name is Lindsay Wyatt. My pronouns are she, her, and I'm the Associate Director for the Culture of Data Conference, and I will be the moderator / Jana White for this session today. We have Allison Rosenthal, our Culture of Data Director, who's going to be managing the Zoom and the tech host. And so unlike this morning with our keynote, we have the chat enabled. So whenever you want to ask a question, go ahead, put it in the chat box, or feel free to raise a hand, unmute yourself. Any of those are fine. I see a lot of you do have your pronouns in there, so that is awesome. But if anybody would like to also add their pronouns, go ahead and click the 3 dots by your name, click rename, and then just pop them in there. So this session specifically is sponsored by the Trailhead Institute, and I have a message from them that I would like to share. Trailhead Institute is honored to sponsor today's session with Julia Brennan, Ashley Heathfield, Devin Miller, and Cari, where we will discuss how collaborative dashboards can streamline and advance data collection, program implementation, funding, and health equity. As a nonprofit public health institute founded with the mission to advance innovation and collaboration in public health, we are inspired by these innovative initiatives that center the importance of enhancing access to and the accessibility of public health data. Trailhead wants to thank Cari, Ashley, Devin, and Julia for joining us here today to share your work and for inviting us to learn about the importance of how we share data and its impact on assisting communities, program planning, policy development, and advancing health equity for all people living in Colorado. So with that being said, we do have 3 presentations today. Each will be 20 minutes long with a 10-minute Q&A session afterwards for all 3. And for this session, we will not be taking a break. So we're going to go back to back to back. So if you do need to take a break at any time, feel free. That is totally fine. We will just not have a formal one. And so overall, this session is titled Dashboards to Action, where we will discuss how collaborative dashboards can streamline and advance data collection, program implementation, funding, and health equity. So with that being said, our first presentation is Health Data Website, Sharing Data in a Unique Way, presented by Julia Brennan. Go ahead, take it away.
Hi, let me share my screen. Oh, it's thinking. Okay. Oh. One moment. Okay. All right. Zoom is. Okay. Can you?
Yeah, Julia, if you are having some bandwidth issues, I'm happy to share your presentation for you if that would help.
You are on mute still. We can't hear you.
Thank you. Okay. This should be good now. So thank you. Can you hear me now?
Yes.
Okay, great. So I'm going to minimize this. See my slides. That's great. Okay, so thanks everyone. My name is Julia at Adams County Public Health Department. I'm an epidemiologist, and I'll be presenting our Healthy Aging website, sharing data. Sorry, it like keeps kicking me off the share screen. Share the whole screen. Okay. So a little context about our presentation. This project came to us from a multidisciplinary team at Tri-County Health Department, Healthy Brain Initiative. And the National Healthy Brain Initiative has identified a need for timely data challenges facing aging adults, and specifically about cognitive health, caregiving, and so the Healthy Brain Initiative team at Tri-County Health Department came and wanted a single source of information.
I am just looking through. I'm not sure if it kicked her out of the Zoom meeting.
Oh yeah. Maybe we can move along to like the next presenter while we help Julia resolve her issues.
Yeah, I think that sounds good. While we work with Julia, our second presentation that is now bumped up to the first is a dashboard for equitable telehealth resource allocation presented by Ashley Heathfield. Sorry, I know I totally pronounced that earlier. Heathfield and Devin Miller. So I will give it to them to take away for now.
Awesome, thank you. All right, let's see. How's that? Great. Okay, well, yeah, we are here to talk to you about our Colorado dashboard for equitable telehealth resource allocation. I am Ashley Heathfield. My pronouns are she, hers. I'm a senior project manager with the Office of eHealth Innovation. My work centers on telehealth and digital equity. And prior to my role at OHI, I was the telehealth and digital equity specialist at the Colorado Department of Public Health and Environment. And I'll turn it to you, Devin.
Hi, everyone. My name is Devin Miller, she, her pronouns. I am a population health unit supervisor over at the Colorado Department of Healthcare Policy and Financing, and I oversee funding that supports innovative telehealth initiatives across the state to support Medicaid members.
All right, so before we dig into the dashboard itself, we wanted to provide some context for the significance of telehealth in our state and set the stage for why our dashboard is important and relevant. As many of you know, telehealth utilization has grown dramatically since 2019. The graphics on this slide are from the Center for Improving Value in Healthcare's Telehealth Service Analysis Dashboard, or CIVIC. If you're not familiar with the resource they have, and you're interested in telehealth utilization in Colorado, highly recommend checking it out. They've added some cool links for like behavioral health only utilization map and demographic data. And overall, we just love Civic and they're a great partner. So these graphics just demonstrate the tremendous growth in telehealth services seen between 2019 and 2021 for all payers, and particularly for Colorado Medicaid, as you can see on the left-hand side. And while telehealth was used prior to the pandemic, stay-at-home orders and social distancing needs created a real need for the relaxation of federal and state regulations. And this made it easier and feasible for providers to deliver telehealth services for more people. On a federal level, prior to the pandemic, Medicare only reimbursed telehealth services for patients living in rural areas. The patients couldn't receive services at their home, and they had to go into a qualifying location. And the list of provider and organization types that could provide telehealth services and be reimbursed were pretty limited. And then many of these flexibilities currently are still in place. However, unless Congress steps in, many of those flexibilities will end, some of them at the end of the public health emergency, but a bulk of them at the end of next year in 2024. So in Colorado, our Medicaid office was pretty progressive prior to the pandemic when it came to telehealth reimbursement. However, the governor had mandated additional flexibilities through an executive order in April 2020 to further increase access to healthcare for Health First Colorado members via telehealth. Many of these flexibilities were codified through SB 2212, including prohibiting health insurance carriers from requiring a covered person to have a previously established patient-provider relationship. It requires HCPF to reimburse rural health clinics, federal Indian health services, and federally qualified health centers for telehealth services at the same rate as in-person services, and as well as reimbursing more provider types for telehealth services. So you can see the line graph on the right shows the spike in telehealth utilization in Colorado, the coincidence of the executive order, and then for context, SB 2212 was signed in July of 2020. And then this, another map from Civic, this shows utilization across our state, with the darker blue counties having higher telehealth utilization rates than the white or light blue counties. So as you can see, utilization isn't equal in the state and seems to be kind of concentrated along the Front Range, or our more urban areas there. So in addition to these giant spikes in utilization, there was and continues to be funding coming into the state and from the state to support telehealth projects. So this is by no means an exhaustive list, but reflects the funding that CDPHE, HCPF, and OHI were working with when we began putting this dashboard together. So CDPHE had CDC funding, which provided funding for telehealth projects related to chronic disease prevention and management. Healthcare Policy and Financing, or HCPF, as I've used several times already, received American Rescue Plan Act dollars to support telemedicine programming. And then OHI was able to take advantage of emergency funding from the Centers for Medicare and Medicaid Services, or CMS, under the HITECH program, and funded 34 telehealth projects across the state in 2021. So with that, I will turn things over to Devin to define telehealth.
Great. One component that we wanted with our dashboard was to align and define telehealth definitions, as even pre-COVID, they varied from agency to agency and in different sectors of the healthcare community. And we wanted to do so because if we wanted to do any type of aggregate analysis with the data collected in the dashboard, or just for simply to have an accurate picture of funding, we wanted to make sure that we were all aligned on telehealth definitions. Here we've defined telehealth as a broad collection of electronic and telecommunication technologies and services that support at-distance healthcare delivery, education, and services. Another component that we wanted to differentiate was between asynchronous and synchronous modalities of telehealth. For example, telemedicine, which is usually live patient-to-provider communication, would fall under synchronous. On the flip side, we have e-consult, which is asynchronous and is usually done between a primary care provider and a specialist. We also wanted to include different modalities that are some more common than others. One of them being provider education, which could be Echo Colorado, which is a virtual knowledge sharing platform where experts lead virtual clinics to support typically primary care providers to deliver best in practice care in their own communities. We also wanted to include remote patient monitoring, which is using digital technologies to collect patient information and then transmit that to providers elsewhere in the state. Mobile health, similar, but has more of a focus on collecting that patient data through mobile devices such as cell phones, tablets. And then also other unique ways of telehealth, such as teletriage, which includes screening patients remotely to determine a patient's condition and the care that's needed. So not an extensive list, but these are some of the main ones that are included in our dashboard. So the development of this dashboard was definitely a cross-sector collaboration between the Colorado Department of Public Health and Environment, Colorado Department of Healthcare Policy and Financing, and the Office of eHealth Innovation. We actually formed the work group in early 2020. So pre-COVID, we knew that this was an area that we could improve on our communication and data sharing between agencies and have better funding allocation across our state. And then obviously with COVID, with the influx of telehealth utilization and influx of funding coming into the state, all the more imperative that we have a dashboard that supports this work. We decided to use a Tableau dashboard. This is the most common dashboard among state agencies, so it seemed like the best fit. We also did pilot testing with our state agency colleagues to ensure that they were meeting the needs within our subject matter experts that we were hoping to use the dashboard. This is also a very much phased approach to implementing the dashboard. We are currently in phase 1, and Ashley will describe the goals and what's included in the dashboard now, and then later on in the presentation we'll go into what we're hoping to also include in later phases.
All right, so while we've got a few goals with this dashboard, the biggest objective we had with this project was to create a tool that supports equitable resource distribution. The dashboard allows state funders to see where telehealth related funding has gone and where it hasn't, and making it possible to identify gaps and plan for a more equitable distribution of resources and support in the state. We also wanted to provide information on state-funded telehealth activities and interventions occurring throughout the state, support state agency coordination and collaboration on telehealth funding. So, for example, if a rural health clinic was funded by the BHA, or Behavioral Health Administration, for telebehavioral health, maybe they'd be interested in receiving funding from CDPHE to leverage their telehealth infrastructure to expand virtual services for patients with chronic disease. Or if my funding at OHI can support the acquisition of equipment and funding from HCPF can support staff time to build workflows for telehealth services, how can we as state partners marry our programs together to offer a holistic funding opportunity to providers? And finally, we wanted to provide a tool that helps state agencies strategically plan for future state telehealth programs and projects. And so I'll just kind of go over this slide pretty quickly. These are just some of the components included within the dashboard. And instead of reading through this list to you, we've got some snippets from the dashboard itself. So as Devin talked through earlier, we have the different telehealth modalities that the 58 projects currently in the dashboard currently have supported. And as you can see, telemedicine or live audio and visual, audio and video makes up a large portion of what's been funded so far. The picture on the right shows the type of organization receiving funding, such as community-based clinics, hospitals, et cetera. But I wanted to call out the other category. So Devin and I will continuously monitor what comes into other across all the components of the dashboard and ensure that if there's a threshold of volume for an option, so say federally qualified health centers in this example, that it would be added to the dashboard as its own category so you can kind of see that. So the dashboard continues to be relevant and useful to folks that are using it. So this slide shows the funded projects as well as impacting what Ray region. So for example, an organization may be located in Lake County that's funded, but has a service area of Chaffee and Summit County. So therefore that project would be counted in Chaffee, Lake, and Summit counties, if that makes sense. On the dashboard itself, you can hover over the county. You can't do that here, but if you hover over the county, you can see how many funded projects are in that area. For example, 4 projects may reach patients in Chaffee County, and then you'd be able to see that. The lack of color means that there aren't any projects in the dashboard serving those counties. And this dashboard is interactive. So when you're actually on it, and we've got the link later on, you can click on a county and the rest of the dashboard will then reflect the projects for that county. So this is available for several areas of the dashboard. So for example, if you want to see projects that are focused on Health First members, you can come over to this side, click that bar, and then the rest of the dashboard, you'll see where in the state those are located, what Ray regions they're impacting, the health focus area, that kind of thing. We also wanted to include information on populations served by the funded organization or the focus for a funded telehealth project to give a sense of the people on the other end of the funding that are being reached, again, as well as a sense of what communities may be missing. On this slide, you can see the type of care that's funded, for example, specialty care, primary care, pharmacy, and then the health focus area with these boxes actually narrows in on the condition that is the focus of the funding. So then here you would see reproductive health, diabetes, or substance use disorder. And then there's a little black form or kind of icon in the bottom of every tab on the dashboard. And this is where state agency staff can directly add their projects to this data set. It'll take them to a Google form to provide information on their project. And once the data is reviewed for just clarity and kind of data cleaning purposes, it'll be published to the dashboard. And then finally, we wanted to have a way for people to download an Excel of the projects in the dashboard in case that's a way they want there's a way they want to sort the data that currently isn't available in the dashboard itself. So folks can come here, download the whole Excel and kind of sort things in a way that makes the most sense or is the most relevant to them.
So who do we hope that uses our dashboard, and why are they using the dashboard? We're hoping that it can be used in a variety of different ways. The first one simply is just to identify shared partners and grantees across the state that are utilizing funding for telehealth. In doing so, we're then hoping to be able to identify gaps of where telefunding is distributed and also where it is not distributed throughout the state. The policy needs is a key piece currently, as the telehealth policy world is ever evolving and adapting right now, especially with the public health unwind occurring. Where are we seeing policy gaps, and how can we improve policies to better meet the community needs? And then finally, this work does not exist elsewhere currently. So this is the first way that we're able to visualize the work of different telehealth funding that's going on in our state, and who is it being provided by, and what populations it's reaching. And to provide a couple of use cases just to make it applicable on how we visualize our colleagues using this dashboard. For example, for maybe a public health grant, staff can use this information on how to understand how many reproductive telehealth programs the state currently funds if they're needing to provide some type of environmental assessment of the current state in Colorado. State staff can also engage clinics currently using telehealth platforms. We pulled out the example of remote patient monitoring. If you're interested in maybe even like looking at policy decisions regarding, reimbursement for remote patient monitoring, you'd be able to use the dashboard and identify practices that are already using this technology and utilize them for feedback and lessons learned. As Ashley described, we have the population focus filter, and this we could see staff who have unique interest in different populations being able to use the dashboard. For example, if I wanted to understand what Medicaid populations are specifically being funded for telemedicine, I would be able to filter the dashboard for that. And then just like Ashley mentioned, there's a lot of opportunities to braid funding across organizations, and this tool provides a way to really understand the landscape of Colorado and being able to partner across organizations to provide additional funding. And again, as an example for, if Medicaid can't fund technology, but we could fund staffing support, we could look for other organizations that could provide that technology funding piece, and then we would be able to step in for the implementation and staffing. So for our next steps with the dashboard, we're hoping to produce a quarterly or biannual report. And this is just a way that we can quantify what we're seeing in the dashboard for leadership and decision makers. And also continuing to socialize the dashboard and making sure that that our partners are using the dashboard. And as new funding opportunities come in, they're being added to the dashboard. So it's live tracking, what's currently going on in Colorado. The link to the dashboard is currently on OHI and HCPUF's website, and I think Ashley just dropped it into the chat. So this is really where it gets exciting as we're kind of completing this first phase, and we really build the foundational structure for how this dashboard can operate. We're looking forward to the future phases of how can we integrate, social determinants of health data, Medicaid population data, to really fine tune and identify where the gaps are currently occurring, or identify where we're really excelling in providing different funding opportunities across the state. And with this process, we'll continue to iterate and improve the dashboard to meet the needs of our colleagues. And when we get to Q&A, we look forward to your questions.
That was amazing. Thank you so much, and for being so swift to fill in real quick. Does anybody have any questions? I do see Mike requested that we have the dashboard, and the link is there. Would like to open it up for a 10-minute Q&A session.
Oh, Lindsay, don't we have to go to the next presentation because we have 3 to get through?
You are correct. My apologies. Julia, are you ready?
Yeah, thanks for your patience.
Yeah, of course.
I was talking to myself for a while. Here's the Healthy Aging site. I'll drop it in the chat. Hi, everyone. Again, my name is Julia Brennan, and I'm an epidemiologist with the Adams County Public Health Department. And I'll be sharing our Healthy Aging website, where we shared visualizations, including some dashboards as a unique way to connect our data with the community. Next slide, please. Just some context about this project. The National Healthy Brain Initiative has identified a need for timely data surrounding challenges facing aging adults, specifically related to cognitive health, caregiving, and impairment. And so our Healthy Brain Initiative team at Tri-County Health came to us and the data team and asked for a single source of information about improving older adult health in Adams County and Arapahoe County. And they asked us to put together this single source of information. And this request included a compilation of relevant aging data and the creation of a web-based data platform to inform the public health program and also policy response. And just as some context, Tri-County, where this was created, has since split up into 3 different health departments. And so I'll be sharing Adams County's information today. Thanks. So the overall driving goal of the Healthy Aging Project was to communicate data in a practical and accessible way for people inside and then outside the public health realm. We wanted to create a single data resource that program staff could use and interact with aging data that's not readily accessible anywhere else right now, and specifically to include meaningful local level data about health outcomes and issues impacting aging adults. We wanted to combine data visualizations with context building text and resources, as well as disseminate community resources more broadly. Next slide, please. We started collecting available data on aging adults, and something important to note about aging adults is there's early aging adults, which are considered 55 to 64, but they're not always included in aging related data. So sometimes the data will just be for 65-year-olds and up. But looking at this data, we decided to collect prevalence, hospitalization data, and mortality data. And then where available, capturing that early aging population as well. And particularly, we wanted it to be at county level or a sub-county level. These are the data resources. We used the American Community Survey and the Behavioral Risk Factor Surveillance System, as well as relevant for our population is the Metro Denver Homeless Initiative Point-in-Time Survey. And then we also use Colorado hospitalization data and CDPHE vital records information. Next slide. These are the healthy aging topics that the multidisciplinary team at Tri-County put together. They're based on program goals and then also the Healthy Brain Initiative roadmap. And so in the middle, we have of importance the Alzheimer's disease, dementia, and cognitive impairment topic. And using survey data, we looked at who is our aging population, descriptive stats and sociodemographics, health behaviors, and food insecurity and homelessness. And then the last 3 topics are mental health indicators, chronic diseases, and acute health issues. And the brainstorming or the collaboration, our brainstorming really benefited from this collaboration to make the website comprehensive and to include all these different aging topics. This table, I won't read it all to you, lists out the aging topics and then examples of indicators that we included. This was important and then also helpful to create a comprehensive picture of aging, and because we wanted the website to be a one-stop shop for local level data. A lot of these are pretty typical indicators used, but just a couple I wanted to highlight were for our aging population and sociodemographics, we included disability status from the American Community Survey, as well as living arrangement, like if you're living alone or if you have a support system in your house. So that can be especially relevant for aging populations. We also included, where we could, acute health issues related to falls, heat-related illnesses, and stroke. And then finally, the main driver of this project was looking at cognitive health. So we have a whole section devoted to Alzheimer's disease, dementia, and cognitive impairment. Next slide, please. So we'll talk about the web-based platform itself. Our website included dashboard components, so that's how we fit into the dashboards and action topic for today. But this web-based platform combined data visualizations, which we'll show you, with context providing text and resources. And we created this with Esri web-based visualization tools on a hub site, as well as Tableau dashboards, which you'll see in a minute. We wanted users to be able to interact with the website, but it can be a lot of information to be inundated with. So we divided up the site into 7 sections plus an AARP livability index link. So each homepage, or excuse me, each topic page is located in this table of contents, and then not shown on this screenshot is the community resources, community health information that is on that main page to disseminate that information more broadly. The result of this website was a really useful resource for supporting conversations and identifying gaps in data, as well as for future planning, and then just overall improving the health and well-being of aging adults. Next slide. This is a screenshot of our Alzheimer's disease, dementia, and cognitive impairment topic page, just as an example. Each topic page has a summary section at the top, which shows our key points and includes some context for the rest of the visualizations. And each topic page summary is followed by either prevalence data or hospitalization or mortality data. And that is how we kind of structured the whole website. And then you can navigate back to the home page and go to other sections if you please. Next slide. For this section, we'll be looking at populations and jurisdictions that were burdened by aging in our county, Adams County. Next slide. Just overall, aging adults age 65 and up in Adams County, 43% live alone, 23% are Hispanic or Latinx, Latine, 21% have an ambulatory disability that impacts their mobility, and 16% speak a language other than English, and that is in our community predominantly Spanish. Next slide. We use Esri maps on our page for a couple different topics to illustrate where in our county these problems are happening to help with geographic planning of resources and prioritization of different areas. And I'll show you 2 of them. This first one is a map of Adams County census tracts showing which areas of the county have higher percentages of aging adults living below the poverty line. And this is super helpful to have this sub-county level information when prioritizing. And again, this is from survey data, the American Community Survey. Next slide. Similarly, this shows the census tracts in Adams County that have a high percent of aging adults with cognitive disabilities. And while we have a whole page about Alzheimer's, dementia, and cognitive impairment, we wanted to also include this indicator from the American Community Survey to also represent what's happening in the cognitive health realm in Adams County. And again, the darker census tracts show the areas in the county with higher percentages of those with cognitive disabilities. And so if you layer these different maps together, they can help you target specific geographic locations, as well as help just for practical planning for programs targeting aging adults. Next slide. Who are our communities that are impacted by aging? This is a huge question, but we will today show you just a few highlights or main takeaways that we found that were interesting that we shared on our website, along with the visualizations. Next. This is a Tableau dashboard that's embedded on our website. It shows hospitalization rates of Alzheimer's disease, dementia, and cognitive impairment. And just as a highlight for our hospitalization data, the conditions, we categorize conditions using ICD-10 codes. And those codes did not have to be the primary diagnosis only. So when you're looking at these hospitalization data, we looked at any inclusion of a diagnosis code, not just the primary, when categorizing these. We were able to get adults age 55 and up in this hospitalization data, so that's really helpful. And we were able to stratify by age group, race, ethnicity, and sex. And so we were able to do this with all of our hospitalization data, which is really helpful. And another highlight was this is the first time that Tri-County used hospitalization data specifically to look at Alzheimer's, dementia, and cognitive impairment separately. So that's a fun fact. When we stratified this data in this chart, you can see that there were higher rates of hospitalizations for these three conditions as people aged. And then white, non-Hispanic people and people of other races who are non-Hispanic had high rates, as well as women had higher rates of hospitalizations than men. So this is helpful to get like a sub-county level information based on these sociodemographics. Next slide. Falls are a really important outcome when looking at aging adults. And so we pulled in data from the behavioral risk factor surveillance system and looked at the percentage of adults above the age of 55 that reported having at least one fall in the past 12 months, and then stratified by age, race, ethnicity, and sex. And women reported more falls than men in the last year using this data source. And interestingly, when you stratified by age, we found that those 75 to 84 reported a high or had one of the highest percentages of a fall in the last year. But then also interestingly, aging adults 55 to 64 had high rates of reporting falls, or high percentage of reporting falls. So that's interesting and just shows how important it is to stratify when you can, when you have enough data. Next slide. This is one of our interesting visualizations. Again, we're looking at hospitalizations and hospitalizations with mental health diagnoses. So we looked at hospitalizations that included anxiety, depression, and then other mental health conditions. And we've included a definition of that here because that can include a lot of different things. When we stratified by age, we saw that anxiety and depression hospitalizations were increased as you aged, but then adults 55 to 64 had higher rates of other mental health condition hospitalizations. So that's interesting to look at. When you stratify by race and ethnicity, we saw that white non-Hispanic people had high rates of hospitalization with anxiety and depression, but Black non-Hispanic people had a higher rate for other mental health conditions. So that's interesting. And then when you stratify by sex, women had higher rates of all three hospitalizations than men, but especially anxiety and depression. Next slide, please. Food insecurity is an important topic for our population and then aging adults as they're on fixed income and things like that. So we wanted to know who of our aging adults is experiencing food insecurity. And we looked at that by age, race, ethnicity, and sex again. And women have a slightly higher percentage of experiencing food insecurity. Non-white communities of color experience much higher percentages of food insecurity than the white community members. And then people 55 to 64 have a high percentage of experiencing food insecurity. So that's just another reason to stratify when you can to understand more about what's going on in your underlying population. Next slide. We're gonna start to wrap up. But before we go, just wanted to highlight our successful collaboration with the Alzheimer's Association local chapter, and then within the health department between data and more non-data groups to bring this all together. This was a unique opportunity for our public health data team to collaborate within our local public health department, and the local Alzheimer's Association chapter. Aging is a huge topic to tackle, so it was really helpful to have this collaboration to identify what our most important topics were, understanding what some underlying things are with the data that we may not know about, that the local Alzheimer's chapter would, and understanding that larger context with the community. So just wanted to highlight that. Huge for providing context for data gaps and then establishing priorities. And finally, just wanted to share the reasons that we thought this was successful. So maybe you can put some of these things into practice, and we'll continue to put these things into practice. We communicated early and often when establishing the proposal for the project and the plan. So by the time we jumped into the actual data, we had a really thorough plan for what we were doing, and it was prioritized. And we knew it was relevant because we had collaborated along the way. We had frequent check-ins, also very helpful. And again, this collaboration allowed us to assess local level data sources and understanding that context around aging in our communities. And next slide. And finally, teamwork makes the dream work. So I wanted to thank my awesome colleagues at Adams County Health Department, Gabriella, Robin, and Adam, and then Melissa, who we worked with at Tri-County, but who's now at Arapahoe County Public Health. She brought us this project in the first place and was really helpful in sharing her enthusiasm. And I know we're all really interested in continuing to work on these data solutions that can highlight issues facing our vulnerable populations, including aging adults. So we're gonna keep on doing that as we continue to build. And this is my contact info at the bottom, but on the next slide, we have the actual link to the website, as well as the Healthy Aging website, as well as the Adams County Health Data and GIS resource page that we're continuing to build as we start up. And we're excited to keep learning about all these different data platforms we can use to share data. So excited to learn more from you all. Thanks. I saw some questions pop up in the chat. Let me see.
Yes, so I misspoke earlier. I apologize. We will have 10 minutes after all presentations to address. So I wanted to say thank you, Julia. I think the final scoreboard is Julia 1 and Zoom 0. So that was an amazing presentation. I appreciate it.
Thanks for your patience, everyone.
Yeah, of course. Way to come back. That was really awesome. We will be moving on to our next presentation and our last presentation of the session, and then we'll have Q&A after. Our final presentation is how the Colorado APCD can inform advancing health equity, presented by Cari Frank. So Cari, whenever you are ready, we are ready for you.
Thank you. And so sorry to give you a hard acronym there. That wasn't very nice of me, was it? So let me pull up my slides here. And thanks for being here on a lovely Thursday afternoon, everybody. So I'm Cari Frank. I'm the Vice President of Communication and Marketing at the Center for Improving Value in Healthcare. And what we will be presenting today is a little just overview of Civic and the APCD, which is what this is founded on, which is the All-Payer Claims Database. And then we have a brand new tool, and this is truly fresh off the presses. We released it today and promoted it today for the very first time. So you will be probably the first to see it. So just in case you haven't encountered Civic before, we are a nonprofit, and our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data to improve health and healthcare. As I mentioned, we are a nonprofit, and we really pride ourselves on being independent and objective. We serve a variety of what we call change agents, which are people like you who have boots on the ground. So, public health folks, hospitals, clinicians, government, employers, all sorts of entities who are working to improve healthcare, all with the consumer in the center as the focus. So the All-Payer Claims Database is what half of the data that I'm going to share with you today is based on. So I just wanted to give you a little bit of background on that. Civic administers the All-Payer Claims Database database on behalf of the state Medicaid department. We have been at it now for a little over 10 years. The database is over 10 years old. It has data from 2009 on, but we really talk about it in terms of like the most robust, which is more 2013 and on. We have over 870 million claims in the database. It encompasses all of the payers, as it says, with the exception of some self-insured payers and employers, because those are voluntary submissions, but otherwise Medicaid, Medicare, and 36 commercial payers are mandated to submit data to the database. It represents the majority of lives, especially with medical coverage. We do have medical, dental, and pharmacy coverage in the database. So a very robust tool to utilize to look at the majority of covered lives in Colorado. And what we do with that data, our job is to take it and make it useful. So we create public information, which is some of the stuff I'm going to tell you about today. But just keep in mind, we also license data as well. So if there's any project that you guys encounter where you're like, wow, I could really use some information and claims could inform it, certainly reach out. We'd be happy to talk to you about any custom project that you might have. So the report I want to talk to you about today, and thank you, Ashley. She shared another one of our dashboards. We do have a whole telehealth analysis and a whole bunch of stuff on our website, which I'll share with you in a minute. But this one is, in particular, is a new one and a new area that we have been diving into over the past year to create, which is the health equity analysis. And what it really looks at is the impact of social determinants of health on healthcare. And we looked at it in three buckets. What was the impact of social factors on cost, on utilization of healthcare services, and then on access to care. And I'm going to jump in and demo it for you in just a second, but I know I don't need to tell all of you guys here on the phone why it's important to look at social determinants of health. But just as a reminder, it's the non-medical factors that influence health outcomes, where you were born, where you grew up, where you work, live, social, forces that are out of your control, racism, all sorts of stuff. And I think it's important to remember that up to 80% of our health is correlated to social factors out of our control, which is a shockingly staggering statistic, I think. So what do we have that we are looking at in the health equity analysis? We had to determine a short group of social factors. We started with these 5. So we wanted them across a broad range of different impacts that people might be facing. So we looked at income, which is the percent below poverty line, education, percent without a high school diploma, employment, which is percent unemployed. We look at also, and those 3, by the way, are based on the American Community Survey. So that's ACS data that we married with the census tract level infrastructure of the APCD that we've built. And then we also have 2 composite measures. One's housing and transportation, which is looking at crowded housing with no vehicle. That's a percentile ranking, and same thing for the race, ethnicity, and language. So it's people of color or people with limited English. And those are based on the CDC Social Vulnerability Index data. And then what we did was we looked at that in those 5 measures, and then we have the ability to bring in the APCD claims data to look at those access, quality, cost, utilization. So we looked at lack of access to care for children and adolescents. Same thing broken out by adults. Also looked at a quality measure that we report on, which is no follow-up after ED visit for mental health within 30 days. We also looked at cost of care per person per year in these certain census tracts, and then 2 utilization measures, all ED visits and potentially preventable ED visits. All of these are based on our community dashboard, which has a lot more measures across all of these categories. But we wanted to start with a finite group that we thought might have the biggest impact in terms of social factors. And we intend to add to this over time. So I do want to pop out to the demo here. So if you go to our website, it's civic.org. Any of public information mostly lives under the SCIT data tab. Public data, our focus areas are kind of our interactive tools. So almost every single one that you see here is actually an interactive tool. That's the community dashboard I was telling you about. But if you wanted to find the health equity analysis, it's here, and I can pop it into the chat here in a second. But at the top of all of our reports, we try to make sure people know how to use it. So there's some information at the top. There's some information about R values, which is the correlation coefficient. For those of you who are statisticians in the room, I am not, so you could probably teach me a lot about that. But this is where we can determine, are there relationships between some of these measures? And it gives them an example of how to understand that. But down here is the Tableau dashboard that you see. Are you guys okay with the size? Hopefully if I can zoom in if you want me to go a little bit bigger. Actually, that's 100% right there. So all the measure definitions, in case you need more detail there, but at the top, you're able to select the social determinant of health that you are most interested in. Income is a big one that does play into the utilization measures, especially the preventable. So I will go to that one. So but here are all of the healthcare measures, depending on which one you're most interested in understanding. Tableau is awful when it comes to using maps. So you just have to click on this button and say, go away, because we have not been able to figure out with the folks at Tableau why that button always pops up. But once you click on different selection options, it should theoretically, and of course, when you're demoing something, it doesn't ever want to work properly, right? It should pop up here, and what you get is a scatter plot up here, and this is a map that hopefully will populate nicely for us here in just a second. But all of these represent census tracts. So this one way out at the upper right-hand side is Pueblo, and they have the highest percent below poverty line. So this particular neighborhood 3 in Pueblo County, has 91% of the population living under the poverty line, and also a very high potentially preventable ED visit rate, which is probably not shocking to any of you. That makes a lot of sense, but it's kind of broken down into different quartiles. Down here on the lower right or lower left-hand side is where you would want to be, where you're not facing as much potential hardship, and you are not having to utilize the ED as much. You also can break this down. So if you want to, my friend at Adams, look at Adams County, Julia, you could actually go to that particular county, and I do not know why this is not populating for me. I apologize. Let me try and refresh this. I tested this no more than like 15 times before we got onto this webinar, and of course, it's not cooperating. Let's see if it'll pop up. I do have an infographic that shows the highlights of the tool. You guys got the majority of what it looks like here. Usually this is a really pretty map right here of Colorado that you could click on, and that would show you the difference across all of the census tracts. One other thing to note, so if you did click on, let's try Adams County again, maybe the map will work. It'll give you the breakdown of all of the census tracts within that county, and then also the correlation between the race, ethnicity in the particular neighborhoods that you're looking at too. So I'm going to let it think about things for a minute, and I'm going to jump over to what we've learned, because that's the exciting stuff. So when we dug into the data to look at the correlation between these measures, we found some interesting things. Some were not shocking. Again, the social factors across all of them, all of the social factors that we looked at, income, education, all of them were all strongly related to the potentially preventable emergency department visits. What we found was that they were also very strongly related to adults not receiving preventive care, But it was interesting to us that none of the social factors actually impacted kids and adolescents seeking access to care or getting access to care according to the guidelines. And that's what we use as our healthcare measure. So I thought that was interesting. So adults won't go or aren't going depending on social factors, but kids, it really didn't impact. And that might be the strength of our Medicaid system. There are a lot of reasons that might be happening. We also did not see any strength of relationship between any of the social factors and the cost of healthcare services per person per year. So that really didn't have much of a relationship. And then where it was kind of moderate to weak, not a huge relationship, was that follow-up for care after visiting the ED for a mental health need. So those were kind of the highlights. Here's across all of them. If you wanted to see it all at once, our infographic, which lives on that same page, this is that access to kids. There was really, green is a weak relationship. There was really no relationship there. Again, there is either moderate or a strong relationship to access to care for adults. Employment being a little less than the others. And again, some of the measures, income impacted follow-up for ED for mental health services in a moderate way. Same thing with housing and transportation, which also makes sense. Again, the cost of care was not really correlated at all. And then that potentially preventable ED visit was very strong relationship across all of those measures. We did break it down also between rural and urban, and you can look at it. You can slice and dice the health equity analysis by rural census tracts and urban to look at the difference. For urban areas, all the social factors were also strongly related to the potentially preventable ED visits. But in rural areas, it was only income and education, interestingly. And then in terms of the adults not receiving preventive care, only income in a rural area really impacted adults visiting their primary care doc, whereas in urban neighborhoods, all of the social factors except employment were strongly related. So if I could dig down deeper into the tool, I would show you how to isolate an area, but my graphic designer did it for us in our infographics, so we can look at it here. We looked at Denver and looked at the potentially preventable ED visit. And I think this is just telling that, community by community, you see one community, every community is different. So even in areas where we had bordering communities, Sunnyside and Highlands, as opposed to, Cherry Creek and Elleria, Swansea. I don't know if I'm saying that properly, but you see a stark difference. So in the Sunnyside area and the Elleria area, both have a higher percent of people living in poverty, and you see a much higher percent, 29% and 18% visiting the ED for a preventable reason, as opposed to those in the Highlands and Cherry Creek area, which have a much lower percent of poverty, having only 1% visits to the ED. Both of them only had 1% of the population visiting the ED. And similarly, when we looked at the adult access to care, we saw a same story when we looked at Sloan's Lake and West Colfax, and then Globeville and Central Park. Those are, either very diverse areas or not as diverse areas. And that definitely impacted the percent of adults who were receiving preventive care. So that's kind of the initial highlights. Like I said, this is hot off the presses, so we intend to continue to dig into, oh, look, it's showing Adams County. We continually will be looking into this data and all of the information that's in here. And if you're interested in a particular area, feel free to dig around. We'd love to learn what you learn. So if you find any really interesting insights, let us know. We would love to continue to build and enhance this to make it work for those of you who are in the public health space. We're continually trying to improve all of our information. And if there's ever any data that you're not sure we have available on our website, please reach out. I'm happy to chat with any of you to, make sure that you're finding things that you need, because we produce something publicly just about every month. So there's a lot of information, and I know it can be overwhelming. Here's my contact information. I don't know why Pete's on there. This must have been an old slide, but I'm Cari Frank right here. So please reach out to me and love to chat with you and look forward to questions. Hope I did that quick enough for us to get back on track time-wise. Okay. I felt like I was going really fast. So please ask me if there are any questions that you have.
Thank you, Cari. That was awesome. I keep saying that technology is amazing until you need to use it. It knows when something's high stake. So
I
don't
know.
worry for everyone.
I'm telling you. Yeah.
Thank you for that. And thank you to all of our presenters for the beautiful data dashboards. They are all aesthetically pleasing and my brain is happy. I want to open it up for a 10-minute Q&A. I do see that Mike put a question in the chat earlier for our first presentation. So I figure we'll start with that. And then if individuals have questions, maybe we'll go presentation by presentation and then kind of go from there. The first question for our first presentation was, what have been your biggest challenges in developing the production of the telehealth dashboard? Also, who was the lead on the collaborative design?
I can start, and Devin, you just jump right in when I miss something. But I'd say our biggest challenge was maybe just, this was something that we were all really working on in addition to all of our other duties. So again, working across different state agencies, I'd say sometimes just really narrowing in on like what was the most important information that we wanted to display, what was meaningful to collect, and then again, what we need to not make public yet. I think it was just making a lot of decisions about like what is going to make the most sense for what we want people to see and take away from this. But we actually were able to work with the Office of Information Technology, and they actually built the dashboard in Tableau with us. So Devin and I have gone through millions of meetings with our friend Brian, and just kind of going through and saying, okay, this looks right, or like this is, can we tweak it like this, and like changing the color schemes and all of that. So again, I'm sure we are not done by any means, but it did take a bit to get it to this point. Again, we've been working on this for a long time, but I think we finally have enough data in there, products within our own groups, and then it was a really great process. So it took a while to get there, but we're both just pinching ourselves that we're presenting on this now. So Devin, if I missed anything, feel free to jump in.
I completely agree. And I think I would just add to that telehealth is such a dynamic concept. And I think we've seen that definitely, coming through COVID with a lot of telehealth utilization, where I think our minds usually think of the patient to provider telehealth visit being telemedicine, but there's so many different components. And that was, we had to work to how do we capture this? How do we make sure we're accurately presenting? Because there is so many different uses of telehealth now.
Awesome. Thank you for that. And before we move on to the next question, I would like to open it up for Julia and Cari. What were your biggest challenges in developing your dashboards?
You want to go first, Julia?
Sure. Good question. I think, well, it was the first time that I personally had built an Esri hub site before, so that was like a learning process. So to do that with 7 pages was, 7 pages, we divided and conquered that. And so that was like a learning process, but like a welcomed challenge. I think also a challenge was to like figure out what was too much information to provide, what like you don't want to overwhelm people, but you want to give people a proper review of the topic. So that was one challenge.
Yeah, for us, this was a whole new beast to marry external data with ours and like overlay and try and determine how to show some sort of relationship. And so I'll be honest, we stole shamelessly from the Washington Health Alliance. They did a similar scatter plot with their APCD and ACS measures and stuff. So we took theirs as kind of a framework, and then we made it kind of ours and thought, like, how could we improve on this? And so there was a lot of back and forth. We worked with our data vendor, who is the Human Services Research Institute. So they helped us develop it. So there was a lot of back and forth about, like, we need to explain this, we need to do this. And like Julia said, like, trying to make it simple, but also make it meaningful for certain communities. So we wanted to have all of the data available, but then that, we always try to put together some sort of infographic or something so that if you're just a user coming on and, like, just give me the highlights, I don't want to, dig into this myself, then it's there for you so you can understand it at a high level. But then if our data wonks and, health equity wonks that really want to dig into their community, that would be a possibility too. So that's what we try to do with all of our public reports, is have high level information, but then also the ability to, like, really drill down. So yeah, and I think everybody we showed this to had a hard time understanding it at first. So we tried to include a lot of info buttons and, the description of how to use it up front. That was really important feedback that we got. We usually, again, I think like most of us on the phone side, we made sure to share it with our partners and other communities so that we got that feedback before launching.
Thank you. Allison, I see your hand raised.
Yeah, I have a question for, I guess, all of the panelists here today. Just looking at your dashboards, it sounds like you guys are finding some like not flattering findings about like different like geographic areas of like that include lack of services or places with just very marked disparities. And I guess I'm just wondering if you've received any feedback about like from people who are impacted by those findings, and if you have any advice for people who may have the same challenge where they have to communicate some findings that are not always flattering, and how to do that in an honest and authentic way. And I guess I can give a little more. I guess I was like thinking about this specifically when I was looking at your dashboard, Devin and Ashley, where you were showing just like lack of services that were in the southeastern corner of the state, and just really identified lots of like gaps, and just wondering like if there's been any reactions or if any of the findings have been controversial, and just how whether or not you've had to do like additional communication about some of those findings.
Yeah, so I'd say that we're really in the phase of socializing the dashboard still. So we haven't gotten any negative reaction necessarily. I think it's also important to point out that it's not necessarily utilization or services, but more so if state funding if there's projects within the dashboard that have funded projects that impact those areas. So if anything, I actually find it like, this is really what I wanted, because I think I wanted to see where the gaps are, like where without being coordinated, it's really easy to be, potentially funding the same areas of the state or the same organizations a lot. Certain organizations know how to work with the state really well, others don't. So I think it was really important for us to be able to highlight those areas that are great, that are missing, so that we can do things differently at the state and make sure that we're doing, if nothing else, active outreach to the organizations in those areas to make sure that they're benefiting from the opportunities that the state has to fund expansion of telehealth services.
Since ours is literally like brand new, we haven't.
Okay.
But when we did the feedback period, so we have an advisory committee that's a multi, organizational community members, all sorts of folks are on it. Didn't get any, again, the biggest challenge I think for them was how to use it and how to interpret it. So we did build in like those tools and resources. But one thing we did have to be careful about was how we display the data and how we talked about it. Originally we had like low income areas on some of our map in red, and like it was a judgment, almost like red and green. I mean, we use orange and green because there are colors, but we had to say like, okay, maybe we shouldn't do that, because we weren't trying to make a judgment statement about, you know, people living in poverty. It was a fact, you know. So I think it's really a challenge in how you present the data and talk about it too sometimes, that makes sure that you're not unintentionally harming certain populations or communities.
And in Adams County, we're a new health department, and so I'm still in the planning stages. And I don't know specifically with this aging side if those census tracts have been used yet, but I know for other maps that we've put together, they're being used to plan where resources are, or to make that a little more evidence-based, or to make sure there's coverage in areas that need it. So kind of more general than our specific project. But yeah, knowing where those gaps are is really helpful at a local level.
Thanks, all.
All right, I think we have time for one more question. Mike put in the chat, Cari, for those that are starting a dashboarding effort for building something at the regional level, can you give a brief overview of the data ecosystem roles, such as data vendors, data creators, private or nonprofits offering these services?
I can tell you how it works for us. We have a data warehouse manager, and then they help us with like the building visualizations, but we do that internally as well. So we have Tableau experts on our team, and analysts on our team. So it depends on the project. For this particular one, we did engage with our data warehouse manager to pull in the ACS data, and then also marry it with the community dashboard data that we do on an ongoing basis. We update that information annually. And then, you know, what we try to do is think about how to tell the story. And that's the folks that live on my team, is we have like user experience and like data visualization experts. And that's, I think, the hardest part. You can have amazing data, but trying to figure out how to convey it in a way that might be meaningful, I think, is the hardest part. I've seen a lot of, well, and we were guilty of it early on too. You can do so many cool things in Tableau, but is it worth it? Is it just too confusing? To Julia's point, like, you don't want to overwhelm people. Like, what's going to tell the story of like a high level and then going down deeper and deeper and letting the users do that? I don't know that I've answered your question at all. But those are things that are coming off the top of my mind. I don't know of any other private and nonprofits that offer services in terms of building the capability. We can do it. Like if somebody comes to us and there's data that you guys have and you want to use some of the data from the all payer claims database too, or even not, we could help you with building Tableau. We have services like that as well. So if that's of interest, please reach out to us.
Awesome. Well, I want to say thank you so much to all of our presenters today. That was a very comprehensive session, and I think that I learned a lot, and I hope that our participants did too. I just wanted to let our participants know, thank you so much for attending this session today. This is actually the last session of our Culture of Data 2023 conference today. So, woohoo! I hope y'all learned a lot today, and I appreciate your attendance. Last things, our slides and additional handouts are on Sketch, where I will put the link in the chat so you can just poke around, look at any presentations you might have missed, circle back on anything. You will also all be receiving a conference evaluation form via email after the conference is over. It would really help us out if you're able to fill that out, give us some feedback. And there will be a raffle for everyone who completes the survey within the next 2 weeks, where you could win one of two $50 gift cards. So I'm always in for a raffle. Last thing is, once again, thank you for attending these sessions. We will be picking up tomorrow morning with our Emerging Leaders Showcase from 9 a.m. to 12, excuse me, the conference is 9 a.m. to 12 p.m. The Emerging Leaders Showcase is 9 a.m. to 10 a.m., just an hour, where we will have 3 presentations from rising stars in public health on environmental data justice, youth-driven community planning, and access to intimate partner violence shelters in Colorado. So we hope to see you there tomorrow, and I hope that you all have a wonderful and restful night. Thank you so much.